Thank you, sir. Thank you so much. In fact, I think Dr. Vitul has given a perfect slot for this talk, because right now all here they are into glycemic variability. Those who have had lunch are having an upswing, and those who are yet to have it are going to have a downswing. So thank you, Dr. Vitul.
So if you want, we can wait for 20 minutes for glycemic variability to clarify. So because 1 hour of a speaker is missed, so we have liberty for 20 minutes. Lunch karke aana aa jao.
No, it's okay. It was
this conference is informal conference.
Yeah, I know. So it was a lighter part of the talk. So let's talk about glycemic variability. What, why and how. So in the next few minutes we'll be just going through what is glycemic variability, HbA1c and glycemic variability, need for monitoring glycemic variability, what are its types, and why would we need to manage glycemic variability, how to identify it, and what are the various parameters, or we call as matrix, to assess GB and the management of glycemic variability. Generally, you see, variability is taken as a negative word. Actually, it's not always a negative word, because variability is one which helps us in the circadian rhythm of so many hormones. Not only that, even carbohydrate metabolism is dependent on variability. So let's not always take it a negative. Here, when we talk of glycemic variability, what we mean is fluctuations in blood glucose, but fluctuations are both up and down. So if we are talking upward, that is postprandial hyperglycemia, and a downward swing in the form of hypoglycemia. Both are considered a part of glycemic variability. And why is this important these days? Because this has a direct impact on the diabetes outcomes and diabetes management. So HbA1c. Now, these glycemic excursions which we discussed just now, up and down, they are very important contributors to diabetes outcomes. Now, the problem with HbA1c is that it gives us an average glycemia. It tells us about average glycemia, but what it lacks is hypoglycemia. It cannot detect hypoglycemia, and the short-term fluctuations are not detected by HbA1c. Although we are going to discuss in the coming slides, we'll have a direct comparison with glycemic variability and HbA1c. So what is the need for glycemic variability? It has been seen that these spikes and troughs, that is hyperglycemia and hypoglycemia, they are directly linked to cardiovascular risk, cognitive decline, and quality of life, in spite of having a stable HbA1c. A person might have a very good HbA1c, but still, if that person is having glycemic variability, he or she is going to undergo cardiovascular risk. So therefore, monitoring glycemic variability, early detection, and managing this glycemic variability is very important. So glycemic variability is basically detected by continuous glucose monitoring. Now, what are the various indications of continuous glucose monitoring? So patients who are going repeatedly into hypoglycemia, or who are unaware of hypoglycemia, subjects who want a better control of diabetes, avoiding hypoglycemia. Pregnancy is a very important indication for CGM, may it be type 1, type 2. Patients on insulin pumps, and any diabetic patient who wants to improve his brittle diabetes. So these are some of the indications, although these days even uncontrolled hyperglycemia patients are also undertaking CGM. Glycemic variability is of two types: short term, long term. What is long term? Long term is fluctuations over weeks and months. This is what is detected by HbA1c or even glycated albumin. When we talk of short-term glycemic variability, now today our focus is on short-term glycemic variability. So this could be variability within the same day, that is called intraday, or between different days, what we call as interday. So these two variabilities, intraday, intraday, they constitute short-term glycemic variability, whereas HbA1c is a long-term glycemic variability. Now let's have a head-on comparison with HbA1c, right? Most of our patients who come to us with treatment, they will not tell you their symptoms. They will not talk of anything else, but they'll show you their report of HbA1c. Okay, sir, ये मेरी HbA1c की report है. So they don't want their diabetes to be treated. They want their HbA1c to be treated, right? So before, or if he or she doesn't have that report, before you advise it, the patient will tell you कि जी मैं अपना HbA1c करवा लूँ. So it is so common. Why? Because it is inexpensive. It is easily available modality. Yes, no doubt, it has predictive value in the vascular complications. We can predict it, and it helps in good diabetes management. There is no doubt about it. But on the other hand, it has a lot of shortcomings and limitations. One, there are few conditions where we cannot rely on HbA1c. Patient has renal failure, patient has some hemoglobin abnormalities. The second point is, the limitation is that it just gives us an approximate measure, just an average glycemia. And the most important point we just discussed just now, it does not tell us about hypoglycemia, which is equally important, and it does not tell us about short-term fluctuations. So short-term fluctuations and hypoglycemia, they are very, very important, which HbA1c is lacking. Now this slide shows us two patients, patient 1 and 2. On the top, both these patients have same HbA1c, 8%. But look at the top patient. Look at the swings up and down. And on the other hand, the patient number 2 is just swinging a little around the baseline. So patient 1 has a very high glycemic variability and high rate of complications as compared to patient 2, whose swings are not that much. So low glycemic variability. Although HbA1c in both these patients is same. See the huge difference this factor makes. Now here we have 3 patients, A, B, C. Patient A, you see what patient A is showing? Patient A is showing both intraday as well as interday variations. Same day also the sugars are swinging up and down, and within the consecutive days also it is swinging. Patient B, a very stable patient, very small swings around the baseline. And what is happening in patient C? Patient C does not have intraday. Within the day the patient's glucose remains stable, but interday fluctuations are again great. So both patient A and C, they have a high glycemic variability, and patient B is the most stable glycemic control. Why do we need to handle glycemic variability? Because it has both short-term and long-term adverse outcomes. So what happens if a patient has a high glycemic variability? There are free radical generation is there is oxidative stress, and this damages the blood vessels in the form of endothelial dysfunction. And this endothelial dysfunction has a direct implication on cardiovascular disease, cardiovascular outcomes. And this all acts by nitric oxide. This is less of nitric oxide. There is inactivation of nitric oxide. This is the pathophysiology. And it has impacts on microvascular and macrovascular complications. Now, not only that, what we are least bothered about is most important. And what is that? That is hypoglycemia. Even hypoglycemia is a pro-inflammatory state. There is release of inflammatory cytokines. and that is again damaging the blood vessels. So let's not underestimate the importance of hypoglycemia. And not only that, एक बार किसी पेशेंट को हाइपोग्लाइसीमिया हो जाए, वो एंग्जाइटी में आ जाता है, उसकी लाइफ क्वालिटी डिस्टर्ब हो जाती है, उसको सेल्फ कॉन्फिडेंस ही खत्म हो जाता है उसका कि व्हाट इज हैपनिंग. सो दिस इज व्हाई वी नीड टू हैंडल ग्लाइसेमिक वेरिएबिलिटी efficiently. If you look at any patient who has diabetes, there are three mechanisms by which there is vascular damage in the form of endothelial dysfunction. Hyperglycemia itself, insulin resistance. Now these two things we are managing very nicely. There is a lot of discussion on insulin resistance, hyperglycemia. There are so many drugs available. But have we ever thought of glucose fluctuations? See how important glucose fluctuations are. Glucose fluctuation is directly causing endothelial dysfunction, and there is generation of reactive oxygen species. So these free radicals, they are directly being generated by glucose fluctuations. Now this is a head-on comparison between chronic hypoglycemia and frequent acute fluctuations. On the top, we have frequent acute fluctuations, up and down swings, whereas the lower one is a chronic hyperglycemia. So which patient do you think is having more damage? The top one. Chronic hyperglycemia is not that damaging. Fluctuations are more damaging. So how do we identify glycemic variability? We have three modalities: self-monitoring of blood glucose, continuous glucose monitoring, and flash glucose monitoring. So just briefly, self-monitoring of blood glucose is very common these days. Everyone has those glucometers, right? Widely available, inexpensive, and you can do it anytime. But what is the drawback? It is patient dependent. रात को क्या हो रहा है? नॉक्टर्नल हाइपरग्लाइसीमिया हो रहा है कि हाइपोग्लाइसीमिया हो रहा है? You can't detect it. You are sleeping, right? But the utility is, it is giving us some broad trends. Patient come to you, tells कि सर मैंने अपनी शुगर में डेली करता हूँ, मेरी 180 रहती है, 170, कभी कभार 200 होती है. So broadly you see, you think patient is safe. Second is continuous glucose monitoring. Now this is the latest and the most important. It is in fact the ideal one. So where continuously, it's a real time, where a sensor is placed, it is attached to your body, it works for 7 to 14 days, interstitial blood glucose is being tested. It is not patient dependent. Yes, it is like costly hai, little costly as compared to the first modality, but it is round the clock happening, and it is ideal to measure glycemic variability. Number 3 is flash glucose monitoring. Flash glucose monitoring, I would say, is in between the top two modalities. Little better than self-monitoring, but less important than continuous glucose monitoring. It is also not that expensive, but again, it is patient dependent. Patient can scan his glucose anytime, it is same. But most important and the wonderful would be continuous glucose monitoring. So what are the measurement parameters? How do you describe glycemic variability? There are so many, they are called metrics. So these are some of the metrics which I have mentioned. Coefficient of variation, time in range. MAGE means mean amplitude of glucose excursions, and time below range. There are some other metrics also, like Conga, MOD, mean of daily differences. So briefly we will be touching these four. They are very important metrics. Coefficient of variation. So coefficient variation is the widely used metric. It is dependent on standard deviation. Its standard deviation is divided by the mean glucose, and it is described in percentage. So for a good control of diabetes, having a low glycemic variability, ideally the coefficient of variation should be less than equal to 36%, right? Time in range. This is the latest thing. Time in range means the time duration during the whole day your sugar remains within range. And what is that range? That range is very clearly mentioned, 70 to 180 milligram deciliter के अंदर अगर आपकी शुगर रहती है लेकिन वो 24 घंटे में कितने घंटे रहती है? 70% से ज़्यादा टाइम, more than 70% of the day. That means 16 to 17 hours in a day. If your sugar remains between 70 to 180, the patient is time in range, good time in range, right? But time below range is also important. If the sugar is less than 70, that is also harmful, right? This should be less than 4%. Less than 4% of the time during the day, your sugar should be less than 70. And above 180, we call it time above range. That should be less than 25%. So these three things are very important: time in range, time below range, and time above range. Now this is another matrix, MAGE, mean amplitude of glycemic excursions, which is nothing but average of the absolute differences between consecutive peaks and troughs, right? So in a very, healthy individual, the MAGE values should be around 36 milligrams per deciliter. This is another metric by which we measure the glycemic variability. Let's give some concentration on time below range. As I mentioned, time below range is less than 70 milligrams deciliter of blood sugar, very harmful. Hypoglycemia, very harmful. So we divide this time below range hypoglycemia into two levels. One is sugars are between 54 to 70 milligrams per deciliter. This is level 1 hypoglycemia. And level 2 is even less than 54 milligrams per deciliter. That is level 2 hypoglycemia. So level 1 hypoglycemia should be less than 4% in the day, whereas level 2 hypoglycemia should be less than 1% only, right? And you can imagine a patient having a blood sugar of 40, 35 and having that triad of sweating and everything. So there is good amount of evidence now that glycemic variability has its impacts and implications. Now we have so many studies. We have DCCT study, we have the Verona diabetes study, we have the Dobbs study, which focuses only on hypoglycemia. So there is good evidence to suggest this, and we know that glycemic variability has adverse outcomes in the form of microvascular complications on your right and the macrovascular complications on your left. So the next big question is, इतना कुछ कर लिया, glycemic variability detect होगी, high glycemic variability है, how to control it, right? So we have two methods, non-pharmacological and pharmacological, as we have of most of the diseases. So first, one should always try non-pharmacological methods. So in non-pharmacological, we have four modalities. One is dietary modification, second is regular physical activity, third is weight management, and the fourth is stress management, most important these days. So dietary modification, we have to consume foods which are having low glycemic index, probably a glycemic index of 55 or less, like citrus fruits, high fiber diet, right, apple, right, and then we have some legumes also, and high carbohydrate diet should be avoided. And most important is we should spread our diet throughout the day, right? Timing of the meals is important, regular exercise is important, but what is more important is the last line. Most of the times we are doing unplanned strenuous exercises. We are avoiding our food, insulin lag gayi, khana khaya nahi, exercise heavy kar gayi. We are very happy, but this is causing hypoglycemia and this is damaging. Now we come to pharmacological. Pharmacological is non-insulin methods, and of course insulin is always there. So in the non-insulin agents, we have three important drugs. One is the GLP-1 agonists, which my colleague has already discussed in the previous talks. Second is the SGLT2 inhibitors. Third is the DPP-4 inhibitors. So we'll briefly touch these three group of drugs. So GLP-1 analogs, you know, very good drugs. They are stimulating insulin release, they are suppressing glucagon release, and they are slowing the gastric emptying. And not only that, they are reducing our appetite also. So that is why some of these are being used for obesity treatment. And this, the very important group of drug, they are showing improvement in all the metrics of glycemic variability. So, this was a study, direct comparison between DPP-4 inhibitors and oral semaglutide, GLP-1 antagonist, right? So, it was a prospective randomized multicentric trial. So, what did the results show? The results demonstrated that if we switch from DPP-4 to oral semaglutide, it is significantly improves glycemic variability. So that means GLP-1 are better, have a better stance than DPP-4 inhibitors. SGLT2 inhibitors, no, these days they are being used left and right, not only in diabetic patients but even in non-diabetics also, cardiovascular disease, huff-rough, huff-puff, so many things. And you know their mechanism of action is increased urinary glucose excretion, and at the same time they have some side effects in the form of urinary tract infections, but a very important group of drug to decrease glycemic variability. And this is another study which was published in 2021, where the glycemic variability was seen by SGLT2 inhibitors and GLP-1 agonists. Now these two important group of drugs were studied in this study, and all these parameters, MAGE, MBG, and time in range, and all these were studied. So what were the conclusions? That both these group of drugs, GLP-1 and SGLT2, they are very effective in improving glycemic variability. So both are considered top slot drugs for managing glycemic variability. Now, vildagliptin, DPP-4, third group of drug, another important group of drugs. Now, this is a very good study done, published very recently in 2025, where 44 patients were taken who were on insulin. So out of those 44, they were divided into two groups, 22 each. So one group of 22 continued on insulin alone, whereas the other group was given vildagliptin along with insulin. So what was the result? Very interesting result. All these parameters were studied. MAGE, MBG, TIR, time below range, everything. So vildagliptin significantly reduced all those metrics, controlled very nicely with vildagliptin. So the end result was that adding vildagliptin to patients who are on insulin significantly improves glycemic variability. And not only that, you can decrease the dose of insulin also if the patient is put on add-on therapy on vildagliptin. So the last modality is the insulin therapy, the optimized insulin therapy. And you know, these days we have latest insulins, insulin analogs, which are trying to mimic our routine physiological insulins in our body. So we have rapid acting insulin analogs, ultra rapid acting insulin analogs, we have basal bolus regimens, we have insulin pumps, we have automated insulin delivery systems, and not only that, we have ultra long acting insulins in the form of dagludec and long acting insulin in the form of glargine. So these two, glargine and dagludec, have really revolutionized the insulin therapy in diabetic patients. So, dear colleagues, in addition to HbA1c, continuous glucose monitoring is very important in monitoring and managing a patient of diabetes, and the recommended target in range should be equal to more than 70% and target below range less than 4%. Not only that, if we look at glycemic variability, the most important parameter metric is coefficient of variation, which should be less than equal to 36%, although MAGE and other parameters are also important. So I think we cannot ignore either. We cannot even ignore HbA1c. So the best would be that if we can combine HbA1c with continuous glucose monitoring and look at the glycemic variability and timely control it and optimize it, that can really give us good diabetes outcomes. Thank you so much.